Very helpful. Thank you indeed for opening up a whole new dimension. Any questions to clarify any point? Because we'd like to go straight to the panel, the reaction panel, hear from them, and then open the floor to the committee members. Are you happy with that approach? Yes. Okay. So thank you very much for those wonderful presentations. We'd like you to please remain in the room with us while I invite the reaction panel to the head table. And joining us now are Jishnu Das, the lead economist from the World Bank. Joining us online will be Nana Danso, and on the panel with Jishnu Das would be Mr. Rashad Masood, who's the Senior Vice President from the University Research Company. So in terms of format, we'll have a 15-minute reaction from each one of the panelists. And then we will invite Pierre and Joe to join back the panelists, and then we'll open the larger panel to interaction with the committee members. Jishnu, you have the floor. And you can go to the podium if that's easier.
So thank you for having me here. I went carefully through Pierre and Joe's beautiful presentations. And I guess, I'll speak a little bit to Pierre's presentation, but I guess the issue that I've had is over the last 10 to 12 years, we've been approaching the issue the other way, just to say what Dr. Nishtar, you were saying, which is, what's the experience of poor people in these health systems, and where are the issues that we need to address as an overall viewpoint? And I just wanted to take you through some of these numbers so that we have a bit of a shared understanding on how things are going. So the current environment is, in Cambodia, India, Kenya, and Vietnam, which are the only countries with full censuses of healthcare providers. We actually don't know how many providers there are in countries. There is tremendous choice and variety among health providers. So every village has on average between 3 and 10 providers in these countries, or close to the village. Half of all primary care services are provided in the private sector. 80% of all primary care services are provided by the informal sector in India, which is providers without any formal training. And the numbers are very similar across all countries where we actually have these data. So one of the big problems I've found is there just isn't enough data. And it's worth pointing out again, people often say that, look, there are 500 quality studies, but there are 120 countries. So that means there are 4 studies from each country over 20 years. And you have to start thinking about what that means in density of data. So in other countries, the numbers appear to range from 20% to 75%. So those are the people who are providing the care. Public sector doctors are frequently absent from duty. Absence rates range from 25% to 40%. The last data we have on this systematically from 6 countries is work we did through anonymous visits in 2005. There's been no upgrading of that data since then. This high absence rate also implies that when you actually go to the public sector, the patient usually sees an informal sector provider. So there's really no difference between the public and the private sector in primary care. Whether you go to the public sector or the private sector, you're going to see a provider without formal training 2/3 of the time, right? The last bit, which comes across quite clearly, is actually healthcare providers in rural areas have enormous excess capacity. So one of the issues that people often feel is these guys are overburdened. Yes, it's true in district hospitals and big hospitals in urban areas and peri-urban areas, they are overburdened. But in all other countries where we have representative samples, and we've slowly been collecting these data over time because the registers are not reliable, you just have to sit in the clinic for the entire day. The numbers are abysmally low. So in Nigeria, for example, which I did, there's 1 patient a day right? Literally in one clinic, we sat for 7 days before the patient came, and the guy had a binocular with which he could look and see whether somebody was coming from the distance, right? So there's just enormous excess capacity in these areas, right? So so instead of just taking you through each of these pieces, which I will do a little bit, what's puzzled me a lot is this question that's come up again and again, which is not, what are the data, how do we improve, but rather how are we to make sense of this? Why is it that for 50 years we've had these kind of care? And the question I've been trying to grapple with is kind of what is the mental model that people really hold in their head, right? And part of it, I made a little bit of progress on that, partly with my conversations within the bank, partly with policymakers around the world, and partly just with doctors. I've been to about 600 clinics. I spent about 2 years of my life sitting in these clinics. So, given how many patients there are, you have a lot of time to chat with these guys, right? So I do. Uh, and it's the following. I mean, we really do need a narrative, and this is where I'd like to push the committee a little bit to think about the health of people in poor countries, a way of explaining the world, right? Something that says, the reason people are suffering from continued ill health is because blank, right? It has two parts. You can think about it as it's a description of the world, and you can think about it as a model of causal relationships, right? So traditionally, what does that narrative look like? I mean, it looks something like this. The reason people are suffering from continued ill health is because we don't have enough doctors to treat people, right? But we've done that, and this was Pierre's very nice illustration from India, which is we build more clinics, hospitals, we reduce the financial burden of care, and I can take you through all these studies. Things improve somewhere, not elsewhere, and certainly not as much as we thought as we did. So we went to the second round of stuff, which said, look, they don't have the equipment and medicines they need, but we do that, and then the people still don't come. So we went to this third round, which said, now we have the clinics and equipment, but we need a needs generation project. So this was my first kind of learning at the World Bank, which was in a project in Paraguay. We built lots of clinics and hospitals that, under a different project, but they were underutilized. So we were thinking of a needs generation project. And as an economist, that's really weird because you're saying, look, you built these clinics that people said they didn't need. Now they're not coming to the clinics that you built that they said they didn't need, so you need a needs generation project to get them there. So we started these needs generation projects that we eventually started calling conditional cash transfers. And these were particularly salient for maternal health. And I think now this is what Pierre was pointing out, and I'll make the point that this is now systematic. 3 very good studies that you must have a look at from Rwanda, Malawi, and India. And I'm using hyperlinks instead of taking you through what these studies are, and hopefully the presentation will be available to you. In all of these 3 very high fidelity evaluations, there is no impact between these conditional cash transfers and mortality impacts, right? So what's happened now? Now, as I talk to the doctors, the policymakers, they've really made life complicated. So now they say, look, doctors are so busy, they don't have time to spend on patients. Some people say they visit informal providers because people like injections and steroids. They don't know what they want. Others say, well, it's the drugs, it's the drugs pipeline that's not working. Other people say people need to take their drugs on time. Somebody else says the market mentality has messed up. Others says, this I've heard, doctors must be motivated. This was a WHO official in India, and we will order the motivation tomorrow. Then there's another group of people who say the government must provide stewardship. And my point is, look, this stuff looks very complex, but it's actually really simple. And there are these 4 pieces of the narrative that have not changed over the last 50 years, which is one is there's a severe problem of access. There's lack of clinics, medicines, and equipment, right? Trained medical professionals follow the Hippocratic Oath. So this is one thing that I found missing from all the presentations that we saw today, which is there's no discussion of the fact that, no, I mean, apart from the very nice project you were talking about on abuse, that's really questioning whether trained medical professionals are anywhere close to following the Hippocratic Oath in these cases, right? The third part, which you need, is that people find it hard to make healthy decisions. And we've numerous code languages for people don't know what's good for them, which ranges from they come when it's too late, What can we do? People here are illiterate and unhygienic. As economists, we call them internalities and behavioral economics. And then, of course, people also demand what's bad for them, like injections, antibiotics, and steroids. But you need to push the blame to the patients if you want to justify what's going on at this current time, right? So eventually you say, look, there are insufficient resources, so there's underinvestment in the public sector, and if we had more money, then all these problems would be solved, right? Now, what we've been doing over time is just sitting with doctors, sitting with clinics, sitting with patients, and seeing what's actually going on. And the worry has been that there's an enormous amount of evidence you're going to find that supports this kind of stuff, but it's of a very uncertain nature, right? So let me give you one example. We uncovered two systematic reviews on public versus private care, both in the same journal, 1 year apart. Each came to exactly opposite conclusions, right? So we went back and unearthed every one of the papers that the systematic reviews covered, right? Here they are. So there were quite a few papers. There were 60 and 114. 16 and 26 actually had a comparison group. So they were talking about public versus private care, but only 16 and 26 of these different ones actually had both sectors. The ones that did not, and the ones that studied the public sector, said the private sector, public sector is really bad, we should rely on the private sector. The ones that looked at the private sector said the private sector is really bad, we should look at the public sector. Did they control for patient mix? You're down to 13 and 14. Did the control for the provider mix? Because there are different kinds of providers, 6 and 4. Did it control for resource differences? You're down to one study. Right? So one of the issues that I do want to bring to the committee's attention is the literature is really going to be sparse once you say how many high fidelity studies are you going to find on quality of care. I mean, Latin America has almost nothing in this area, right? So we've been trying to look at this black box of provider-patient interactions. I have a database of about 20,000 interactions around the world now. And the narrative seems to be fairly clear now, which, at least from these studies, which is when it comes to medical care, people make reasonably good choices among the ones they can choose, right? But their options can be very limited, severely deficient, and in addition, there's specific things on which they need help. So let me just give you two examples, and then I'll kind of stop there. So this does imply two things which are important. One is that qualifications don't imply knowledge, and I'll show you what that is. And the second is that doctors are motivated by many things, and they respond to that motivation by trying to do better, right? But these two things together, because in many cases, doctors are not going to have any incentives to do better, and they're going to have terrible knowledge, you're going to land up with situations where people just receive absolutely horrendous care, right? So I'll give you one example of why these old kind of narratives lead to weird policies, and then and there. Again, I won't take you through the work that's been done on this. So let me give you two examples of sophisticated decision making among patients and show you why these are hard to do. So here's a study where we looked at how far do people travel to access different doctors, right? How did we do this study? We went to 100,000 people in 100 villages, and we asked them whether they'd gone to a doctor and where they had gone, right? We then went and measured the objective knowledge of each of these doctors with a test, right? So the whole process took us 2 years, but what we found was that the further people were traveling, the greater the knowledge on these objective tests that we gave them, right? The other piece we found was that people who were richer were always traveling less. They were willing to pay more money to go shorter distances. But you can't have this correlation unless people have a really good idea of which doctor is more knowledgeable and which doctor is less knowledgeable, right? The second one we've been using, because we work with the private sector, which is the biggest sector in all these countries, is prices, right? So one of the ways as economists we think about whether a market is working is to say, is better quality rewarded? And it is very heavily rewarded in these markets. The more adherence to checklist on a medically objective checklist that you have, the higher the prices these doctors are able to charge, right? So where is it that they go wrong? They never penalize doctor for doing things that patients don't need. So we do not find that doctors are ever penalized for giving a whole, a bunch of stuff that patients don't need. So there's no incentive in this market for cost cutting, or if people are getting unnecessary antibiotics, which they're getting all the time, you're going to land up with pretty severe health problems, right? One thing to note is this problem of antibiotics in all the studies that we have looked at is much worse among the public sector doctors than those without formal training. So people without formal training are pretty afraid of doing this stuff. And it's equally bad in the public sector, right? And there's a very nice paper by Janet Curry and others from China that shows that this is very strongly linked to financial incentives. So I'm not going to take you through this, but just, this is what an interaction looks like. And we have data now from from at least 4 different countries. So we have Kenya, we have China, we have India, and the numbers are very similar everywhere. You get about 4 to 5 minutes with a doctor. If you come in with severe chest pain and anxiety, about 16% will ask about pain radiation, and about 24% will ask you to get an ECG, right? You'll get all kinds of medicines. So these were the ones that you actually need for that you could justify, but these are all the medicines you will actually get. And the bigger the font, the more likely you are to get it. This is not just, so one of the issues we've had is people often say, well, that's India. Well, India is a sixth of the world, so it seems kind of important. But, and I also thought that this is just India, right? But it's not. It actually turns out that it's rural China, it's Kenya, it's rural India, it's urban India. Basically, everywhere we are managing to now do these studies, we are finding similar numbers. Why is this happening? One is qualifications are not knowledge. So here are all Indian states where we have now surveyed close to 8,000 doctors. And these are the fully qualified doctors and their knowledge. And these are people without full qualifications. So what's true is within each state, the doctors who are fully qualified have more knowledge than the ones who are not, right? But the fact of the matter is if you take these states, the doctors without any formal qualification have much more knowledge than the doctors with formal qualifications in these states, right? So you have to think about that, and this is something we are now finding in many, many different countries. So we have done Kenya, Uganda, Tanzania, Togo, Nigeria, and Senegal, which is it's always the case that doctors with formal qualifications have more knowledge, but there's significant overlap in these distributions, right? Which means there are many, many providers without formal qualifications who actually have more medical knowledge than the people with formal qualifications, okay? Second is knowledge does not imply practice. So this is exactly the same doctor in their public sector and then their private sector practice faced with the same patient. And just moving the same guy from his public to his private sector, and I say his because they are all his, moves them from being the worst doctor in the entire system to being the best doctor in the entire system, right? Again, this is something we're finding everywhere, and we call this the no-do gap, which is if you ask doctors what they would do when faced with a patient, which is this red bars, and then you send the same patient to them 6 months later, they do in practice a lot less than what they told you they would do with the same person, right? And again, this is not just India. So China looks like this. This is Delhi. This is 2 different parts of India. But we now have evidence from 2 more countries that suggest exactly the same patterns, right? Okay, what does this all mean? At the end, when you put it together, this has enormous health costs. But the other part is it's also going to have enormous financial costs, right? So as an economist, part of our problem is we deal with finance ministries and they say, okay, where do you guys keep saying, the health people keep saying we need more money. But if you start computing what are the avoidable costs and what's the fraction of all costs that are medically unnecessary, it's ranging from 81% in rural India to 90% in China, 75% in Kenya. That is, you can just cut that cost out of all primary care and you get no difference in outcomes whatsoever, right? So it's going to be really hard to say, more money is needed, because if you can increase quality, you can do an enormous amount more within the existing budget envelopes, right? So what's the conflict between, these are my last 2 slides, what's the conflict between this data and old narratives? Take, for example, the public sector in India, right? It hires the best doctors in the system by knowledge because it hires fully qualified doctors. They are the guys who can, who have that money. It gives them absolutely zero incentives, whether it's financial, whether it's career, whether it's geographical, to do well. So here is the link between wages and how good they are. That's about as zero as you can get in a correlation, right? I mean, there's just nothing there, right? So consequently, the care of the public sector is similar or worse than among informal providers in rural areas, right? And then we go ahead and make it worse. We say we should follow WHO norms of putting a doctor for every 5,000 patients. Makes sense in an urban area, maybe. You find if you go and put a doctor in a northern area in Kenya, so say in the desert areas, right? You've landed up with villages that have 20 people in each village. Where are you going to put the guy? Whichever village you put them in, his maximum catchment is 20 households, right? I mean, there's just nothing you can do about it, right? So when I went to Turkana, for example, which is in the north, one patient comes in on a camel every, 3 days, right? So here's doctors and their patient loads. These are public sector doctors who are not very busy. That's the one patient he saw. These are the guys who are really, really busy. This is the 95th percentile of the business distribution. That's all the free time they have, right? So, these results have now been replicated, but imagine how we are getting these results. We're sitting in 600 clinics in the country for a day at a time and just counting patients, right? I mean, that's, this has just been backbreaking work, but we now have these data from Cambodia, Vietnam, Kenya, and Paraguay, and they're all showing exactly the same patterns, right? So I just want to conclude here. So I think, like the previous speakers, I agree that we need to think institutionally. For me, institutionally has a very different meaning, and that's what I want to think about, which is institutional analysis for me is thinking about financing, accountability, and the link between the two, right? So for example, let me give you 3 examples. How do we balance costs versus access, right? And I don't think these are different. So providers in rural areas are immensely expensive because they see very few patients, right? I mean, you divide their salary cost by the number of patients they see, they are the most expensive doctors in the whole region. Urban slums, from the DHS data, have higher mortality and worse medical care. So how should we balance the two? Do we put our next doctor in the urban area or in the rural area, right? Who produces medical education, who pays for it, and how is it to be certified, right? So one of the big problems is if the public sector hires doctors based on qualification, regardless of where your degree is from, and wages are independent of actual knowledge, you're just going to get degree mills that afford degrees because it doesn't matter what you know, right? And that's exactly what's happened in India. So who has the right to certify? Who has the right to test? How do we manage this whole thing? We don't know. And lastly, kind of what is the role of the patient in generating accountability, and what's the linking between financing and accountability? So I often find people say, oh, out-of-pocket payments are terrible. I agree, out-of-pocket payments are terrible if you have other systems of generating accountability, right? But if you have no admin systems, your state capacity is at zero, right? And this was kind of one of the big issues I had with the peers presentation, was I don't understand, all the management and effort capacity is coming from IHI. When you remove that completely, there were great results from the South Africa one, but we are not seeing, in all the interventions that we are doing with the government, we are not seeing long-term sustainability once you remove that basic piece of capacity coming from outside, right? And we don't fully understand how to deal with that. And there has to be some link between patients, having a much greater voice in what they're getting and being able to act on that. And I'd like to, think hard about what that looks like. And last, kind of, what's the role of ex-ante regulation versus ex-post liability? Liability plays a very important role in the American medical system. There are very few studies that look at courts. There's a very nice paper from China that looks at malpractice in health affairs, but we don't know much about how malpractice is being, assessed. What are doctors liable for? If you kill a patient, can you get away with it? Not, what exactly are these systems looking like? And as a result, what we find in a lot of countries is they move to ex-ante regulation on things that don't really matter, right? So for me, these are these big institutional questions that have plagued kind of where we are on these various different things. And my reaction to these pieces was, look, I understand that you can get improvements, you can do a bunch of stuff, but when you start to put this on regular systems where you haven't been invited to come in and work, or where people are struggling with how to even get doctors into their clinics, there seems to me a bit of a disconnect that we really need to start thinking about. I'll stop there. Thank you.